Hello, my name is Carrie Allen, and I'm a pharmacist who works for Omnicare. I'm here to present to you the Medication Pass Fundamentals, Part 1 of our 3-part series. We've made this easy for you because I'm not going to read everything off the slides as much as you may want me to. There's a lot of detail provided for you. What you can do to download the slides and have access to all that dense information is go to the little link above the screen where it has a paperclip, and you click on that. Another little side screen will pop up, and it has a list of items that you can download and print right from your computer. Another thing we've done to make things easy for you is we've chaptered this particular program so you can jump as much as you want from one chapter to the next chapter. So the first thing to do in order to do that is click on the slide list button. To me, it kind of looks like a bunch of little windows. And then the second thing that you're going to do is click on the chapters button. That looks like 2 little lines off to the side. And then you click on the chapter. It's going to show you the window talking, and if you want to get back to seeing the slide and me talking together, then there's a step 3 that shows you how to do that. The intended audience for this program are really any facility or community setting that offers Medication Pass as part of their services, so skilled nursing facilities and assisted living facilities alike. You will find me referring to the State Operations Manual, which is mainly related to skilled nursing facility regulations. But what you need to understand about that is those are minimum standards of care. So really anything I'm talking about in this presentation will help you reduce medication errors in any kind of facility that you work in. This is for clinical and non-clinical management. So yeah, all of your nurses, but also administrators and other people. Staff that are involved in performing medication passes on a day-to-day basis, your nurses, your medication aides or technicians, should you have those in your facilities. Staff that may require an annual refresher, an occasional refresher, or retraining secondary to a medication error. And any facility that's been permitted by their state governing body to use this training as part of a plan of correction. We're going to go over a little bit about the resident population, safety, and common medication errors, privacy, dignity, resident rights, state survey and associated F-tags, as well as the error rate calculation for MedPass. And again, if you are an assisted living facility or maybe an MHMR facility and you don't get those kind of tags, you don't have those same kind of surveys, this information actually will apply to you as well. We're going to go over MedPass observation, both the facility goals and how they should approach it as a whole, and preparing for MedPass, what you should do to get ready for MedPass, and some basics on controlled substance management. So who is your resident? It's important to know who your resident is, and each of your residents is going to be different. They're all individuals. So maybe it's a frail elderly person or someone with a debilitating chronic disease state. Maybe it's someone who recently had surgery and is only going to be in the facility for a short time. They likely have lots of disease states or lots of medications. So you have to understand what makes these residents more vulnerable to being at danger from having a medication error or being in danger from having side effects or adverse drug events just by virtue of how frail they are or how many medications that they have. This is one of my favorite definitions of a medication error. And I'm not going to read the whole thing in detail to you, and you are thinking to yourself, I'm quite sure, who has a favorite definition of a medication error? Pharmacists. And my favorite part of it is that it points out it's preventable. Medication errors do not have to happen. If you handle medications in any way, they do happen, but we can prevent them, and we can work to stop and minimize them as much as we can. It's a preventable event that may cause or lead to inappropriate medication use or patient harm while in the hands of the healthcare provider or even the patient or the consumer. The best part about this slide is the part that's circled at the bottom. Administration, education, monitoring, and use. The key part to this, and they're all really interrelated, is education. If you don't have the proper education on the medications that you're giving or the processes you should be using, you're going to have medication errors related to administration, monitoring, and use. So towards that end, it's really important that you never administer a medication that's unfamiliar to you or you don't have a good working knowledge of. Call the pharmacist, look it up in a drug reference. And if you have to look it up 3, 4, 5 times, don't be embarrassed. I've had to do that myself. Sometimes things just don't stick with you. Drug references are available to you. Some popular ones are shown on this slide, like the physician's desk reference, but you may have one that you like better, and that's okay. This is not a drug reference per se, but if you have medication aides or technicians that work in your facilities, either assisted living or skilled nursing facilities, it's an excellent pocket guide that gives you information on do's and don'ts and administration procedures and pain, all sorts of things. Now, OmniView, which is our customer information site, has great information for you for drugs. So we have actually a little part you can click on, type in a drug name on OmniView, and it'll give you great drug information. We also provide to you as a service an external link to a very reputable site. Doctors use this site, nurses use this site, pharmacists use this site, and you can type in a drug name. It's going to tell you different dose forms. It'll show drug pictures. It tells you about typical dosing, what to do if there's a problem with someone's kidneys, those kind of things, and those are great electronic resources. Also on OmniView, we have the Geriatric Pharmaceutical Care Guidelines, or the GPCG. And this has really detailed guidelines on it, but what people typically use on day-to-day basis is the clinical tools. And what those provide to you are these wonderful PDFs that you can download. One of the best ones that people use all the time is the common oral dosage forms that should not be crushed. Not everyone has all of those memorized off the top of their head, believe it or not. So it's wonderful to have a downloadable, and it gets updated regularly. Medication errors as defined by the State Operations Manual are basically the observed preparation or administration of drugs that's not in accordance with how a physician ordered it, how the manufacturer wants you to give it, or accepted professional standards and principles. So you got to act like a professional here. They classify them as significant, which means actual harm, or significant potential for harm, or non-significant, lower likelihood of causing harm, but still thumbs down. You don't want either one of these, all right? If you are not subject to a survey by the State Operations Manual, I'm pretty sure you can tell you don't want any significant medication errors, you don't want to give things the wrong way, and you want to minimize even the non-significant errors. So you can see how this really applies to anyone. I have some F tags listed up there, but the point is you really want to make sure that your facility is free of medication error rates of 5% or greater. Think of how many medications are passed at your facility. 5% can be a lot. Residents need to be free of any significant medication errors. Those ones that cause actual harm, yeah, no matter what facility you're in, we want to make sure that doesn't happen. This is a slide that has a bunch of examples on it about significant versus non-significant errors. And I'm going to go through a few of these. They're there for your reference. I'm not going to go through all of them. What I want to say before I get into that, though, is that you have to think about context. Medication errors, especially if you've got a surveyor or someone like me looking at them, are defined on a spectrum, really. It depends on how frail your resident is. If your resident is very, very frail, the smallest medication error can have a very, very deleterious effect, could cause a lot of harm. If your resident is more robust, it's still bad, but it might not be as harmful. The other thing to think of is what kind of medication it is. That's going to make a difference as to whether it's significant or non-significant, those kind of things. How often it happens, the scope at the facility. If you're giving a medication that's wrong to 50 people at the facility versus 2 people at the facility, neither one is great, but 50 people is a lot more significant. That shows you have a big problem at your facility, okay? So while I'm going to go through the significant and non-significant, I do want you to remember the goal is no medication errors. That's our goal. Let's start with ibuprofen. That's just your over-the-counter Motrin, that kind of thing. 400 milligrams by mouth 3 times a day is the order. If you miss the morning dose of that, that's probably not significant. But if you miss the morning dose of that and the resident is in terrible pain, they can't do what they want to do, they are having a very poor quality of life because you missed that morning dose, That's significant. So you can see how it flows situationally. All right? Digoxin is a medication that works on your heart, controls the rate, has a very narrow therapeutic index, meaning that you have too much or too little, bad things can happen. If you miss a dose of that, that's by definition significant. If you give a multivitamin to the wrong resident, this resident has no orders for a multivitamin, okay, that's probably not significant. It's probably not going to lead to a lot of harm. If you give warfarin, which is also known as Coumadin, or Jantivin in some cases, that's a blood thinner. And I can tell you almost anything associated with warfarin is probably a significant med error. If you give it to the wrong resident, someone who has no orders for it, we're going to have to monitor, we're going to have to make sure they don't bleed out. That's a significant medication error. Medication timing is important. Generally speaking, you have an hour before the time on the MAR and an hour after the time that's scheduled on the MAR to give the medication. But what you have to think is some medications are directly related to timing and safety. So for an example would be glucotrol or glipizide, an anti-diabetic medication that you take by mouth. Well, if you take that by mouth 2-3 hours early and the resident's blood sugar is going lower and lower and lower before they have a chance to eat, this can be a problem. They can fall. They can have hypoglycemic shock. You can cause a lot of damage by not timing that correctly. So while that 1 hour before and after rule applies to a lot of drugs, it doesn't apply to some. You have to be very specific for some. And you also have to think about drug-food interactions and those kind of timings, and enteral feedings and drug-drug interactions. Some drugs you can't give close together. The State Operations Manual has their definition of medication errors, and as I may have mentioned, the medication error rate goal is that it not be 5% or greater. It needs to be lower than 5%. And they think that when you're over 5%, you have a whole systemic error, and they do a whole calculation about this. The goal, again, and the important thing to know, is that we want no medication errors. We want a 0% rate. If you're interested in how the state calculates it and how I, as a pharmacist, will calculate it, here is the calculation for you. But just know, lower is better, whether or not you do the math. There's a bunch of agencies out there, some of them are listed on this slide, that go through and they research process issues related to medication errors and patient harm. The one thing that they all agree on is that no one makes a medication error entirely on their own. It's usually the process, the organization, and all of the issues associated with that organization that ultimately cause medication errors. So you're not alone in this. It's a whole system. And therefore, the facility should have a goal for medication pass. They should work together with staff at all levels, and I'm talking from janitorial staff to CNAs, to nurses, to the administrator, to the Board of Regents. They have to provide input and develop a facility culture that increases resident safety and decreases medication errors. This is a whole busy slide about different F-tags that are often cited in relation to MedPass. If you are not in a facility that receives F-tags, you don't have to worry about it. The important point is that these are different categorizations from the federal government about things that have happened to people in the past that were bad enough that they had to categorize it. So we're just going to go through the concepts. You understand where you may be going wrong at your facility or individually and what you can do better to fix it. So you know what everybody's looking for and how to do your job better. F-Tag 281 is professional standards of quality. A great example of that is, hey, don't borrow medications for one resident from another resident. We all know that. No borrowing. Quality of care. If you don't have a great plan in place for people who are in pain and their quality of life is bad, then we're providing a poor quality of care. Unnecessary drugs, for me, my family, and anyone I care about, and all those residents I take care of, I want no drugs that shouldn't be on the profile, no unneeded drugs. I want the lowest possible dose of the drugs that they absolutely have to be on, and I want to limit the duration of drugs that don't need to be given over and over again. And obviously you want to take off drugs that are causing problems. And this is something your consultant pharmacist comes in and really focuses on every month, amongst the many other things that they focus on. Medication errors, we went through that in great detail. Pharmacy services is just making sure you have a coordination of services so every resident gets the medication that they need at the right time. Storage, labeling, and controlled medications, this is pretty obvious. If you've got a refrigerated med, you've got to check the temperature to make sure it's refrigerated at the right temperature. Labeling, you have to make sure that if you have an inhaler or something like that, this one doesn't have a little label on it, but it should have a little label on it because I have it out of the box, and I sure don't want to give it to the wrong resident. I've gotten those calls. Carrie, we gave this medication to the wrong resident. We shouldn't have given it to them. And they say, you know, what do you think, what should we do? And the first thing I say is, that is so gross. And then I go on to tell them what to do. Controlled medications. You have to have a process to make sure you know where your controlled medications are and nobody's stealing them. Resident rights we're going to go through in great detail, but just remember one of the most important ones. They have the right to refuse medications and the right to refuse treatments. Our last F-tag I want to go through is infection control. The CDC has a website actually specific to long-term care and infections, and they say that, yeah, data's limited, but they estimate probably 1 to 3 million serious infections occur every year in these facilities. My personal estimation is that it's probably higher than that. So you have to make sure you have good infection control techniques, and I will talk about that ad nauseum through these presentations. This is just a slide to show you what I look at, what surveyors look at, what you should be looking at in terms of medication pass and medication errors. You know, all these things overlap. Where they overlap is the resident. This is someone cares about. This could be you. You want to take good care of your resident. Resident care is the most important thing. So you do what you're supposed to be doing all the time, even when no one is watching you, because that is the safest thing for the resident. The facility should have an approach to medication pass because, you know, the day-to-day business of caring for residents in a skilled nursing facility or an assisted living facility or even an MHMR facility is heavily reliant on medications as the primary mode of treatment. We're not doing surgeries. We're not doing things like that. And because medications are so prevalent and they can cause damage, it's important to train the trainer. If you haven't heard that phrase before, training the trainer is just a way to make sure you have excellent control over your processes at the facility. So facilities should adopt a consistent process to perform a med pass and continually monitor it on their own. So I'm talking about the director of nursing, the assistant director of nursing, any other clinical management needs to monitor med passes and be adept at knowing how to monitor med passes for their own people. And this will help you achieve the safest environment and the lowest error rate possible. By all means, involve your consultant pharmacist and the nurse consultants in this, but day-to-day, hands down, the facilities who do this have low medication error rates. Other ways that you can reduce your medication errors are to lead by walking around. So the director of nursing, the assistant director of nursing, the administrator, they get out, they walk around, do a couple rounds throughout the day, and they informally observe medication pass as it's going on. The last couple slides were about how you would formally do it. This is an informal way to do it that should also be done by the facility. Because honestly, you're not going to know when you need to clean up your backyard if you never go in your backyard. You've got to see what's going on. And when you see something wrong, non-punitive coaching, gentle teaching, and catching people when they're doing it. They're going to remember what's happening. You don't say it in front of the residents, and you help them do their job better. Across the board, facilities who do this have low medication error rates, they have great relationships between clinical management and staff, and they have wonderful relationships with their residents, which to me is super important. Peer shadowing and review, this is a wonderful way to help all of those ideas about med pass stick. So you have nurse to nurse, nurse to med aid to med aid, watching each other and giving each other pointers, taking some time throughout the month to do that. When we do that, and I have a technician watching me, maybe making an IV, or I have another pharmacist watching me, it's nerve-wracking at first, but I get so much out of it. I learn, and they teach me, and I teach them, and we become more efficient. Please report, discuss, and correct your medication errors, and involve pharmacy in that discussion. What we can do is figure out what's happening at the facility that's leading to those errors. And I know that I've made errors that other people have made, and if I hear a story about the errors they've made, or they hear a story about the errors I've made, like once I mixed phenytoin wrong in a bag and the nurse called me, I will never make that mistake again. And I tell other people about that mistake, just like I'm telling you, because I don't want you to make that mistake. There is basically a Bill of Rights, and that we're not going to go through all of them. We're going to go through the ones on this slide, although I'm not going to read through them right now. But medication administration really involves preserving dignity and residents' rights. They have the right to be treated with respect, including how they're addressed. Honey, baby doll, darling, you may be trying to show care, but that's marginalizing. These people have lived lives and contributed to society. Some of them have served in wars that helped protect your rights and mine. I think addressing them in an appropriate manner is the right way to show them respect. Make sure you're not interrupting the resident while they're eating for administration of medications without an order, and minimize that as much as possible. Try not to wake people up in the middle of the night to give a medication that could be scheduled at a different time. Now, I had a case with a resident who was being woken up at 3 a.m. for a pain medication. I went to her and said, hey, we can schedule this at a different time. Do you want us to do that? And she said, no, you know what? I like it. It benefits me. Now, other people are not going to be like that. I would not be like that. Don't wake me up in the middle of the night for any reason unless you absolutely have to. So it's individual. You need to find out what's right for the resident and do that. Explain medications and any procedure that you're going to perform. I'm a pharmacist. A lot of times nurses won't explain to me before they're going to do stuff. And I like it when people explain stuff to me, and so do other people. Don't assume that they know. Know enough about the medications to answer questions that the resident may have about it. And if you don't know, don't be embarrassed. Say, you know what, I'm going to look that up for you. I'll be right back with an answer. Have those references available. Again, the resident has the right to refuse medications or treatments. You don't want to force them to take a medication. And the facility should have policies and procedures to help guide you on how to document these refusals and when to notify the prescriber. The privacy during medication pass is a big thing because we give so many medication, and it is our primary mode of treatment. Sometimes people just get in the habit of giving them all willy-nilly all over the facility, and you don't want to do that. Primarily, you want to give them in the room. And because people live here, that's their home, you're going to knock on the door before entering and identify yourself. Mrs. Jones, it's Carrie. I'm here to give you your medications. Do not administer medications when the resident is receiving personal care or in the bathroom. From time to time, what I will do is I will go talk to the resident and say, hey, at some point today, I'm going to come in the middle of your medication pass. Is that okay with you? But I'm not going to tell the person who is passing your medications because it's just an observational thing. And they'll say sure. They always say sure. And I'll come in, and I can't tell you how many times I've come in, the resident's sitting on the toilet or getting some personal care, maybe some peri-care, and the person giving medications is trying to force medications down them while they are receiving these very personal things. That's not appropriate. We don't want to do that, and it's not sanitary. Medications, as I said, are ideally given in the privacy of the resident room, but especially those ones given down a G-tube or nasally, injections, obviously vaginal and rectal administration of medications, even patches because you're adjusting the clothing. Have to keep that privacy going. HIPAA. We're all familiar with HIPAA, keeping resident information private. So you need to cover your MAR or go to a privacy screen on your computer if you have computers, and make sure that no one can see what's going on with that resident. When I first started in the field, I knew it was something we shouldn't do, but I thought, well, who's really going to care? I've seen people do unimaginable things. They will go behind the nursing counter. If the MAR's on the cart, they'll flip through it. They're looking at people that aren't even related to them. I don't know what they're looking for. I don't know why they care. But people are weird, and they're going to do stuff like this. So you need to, be aware. I had to put this in this day and age. We got the pretty picture of the phone and all those little icons for social media. This includes technology, HIPAA and technology. There are no selfies at a facility. There is no blogging or posting about stuff that went on that has resident information. I know we like to talk about work. This is not the way to do it. You do not take pictures of residents. You don't comment on residents. You don't tweet about residents. That violates their privacy. People have been fired for this, and rightfully so. The resident has the right to be free from physical and chemical restraints. So medications, especially psychopharmacologic medications, the ones that work on the brain, are not to be administered for staff convenience. An example of that is you're talking to Sally. She's got a great story from the weekend. You want to hear that story. But Mrs. Jones is down the hall. She's wandering. She's crying. It's 9 p.m. You think she should be in bed. So you say, you know what, she has a PRN Ambien. Now, she didn't ask for it, but you've decided she needs to go to bed, so you just decide to give it to her. That is chemical restraint, and it's not appropriate. Physical restraints, holding someone down so you can give them a medication, is also not appropriate. Let's talk about getting the cart prepared. You got to slow down. You got to take your time and get prepared. Otherwise, you're going to find yourself at the crossroads of time and accuracy and safety. Now, if you're at that crossroads, we err on the side of accuracy and safety. However, for some medications, as we mentioned earlier, safety is directly related to time, so you need to keep that in mind. Professionalism. You want to get that name tag on before you start, and it needs to be able to be seen. You have to have a professional appearance. We're trusting you to act as a professional. You should look like a professional. So if the resident looks like they got out of bed, well, this is their home, that's okay. This is your place of work, that is not okay for you. Keep that med cart clean, keep it stocked and organized. Infection control, this is big and bold and important. Clean those pill counters every time you use them. Clean the pill crushers, don't have a bunch of pill bits everywhere. The med cart should be cleaned. Glucometers should be cleaned. And with glucometers, special cleaning agents may apply, so you need to know what those are, and they vary by manufacturer. Those hands need to be washed. Hand sanitizer needs to be available, probably in large quantities because you're going to use it a lot. Please use tissues and paper towels. Have them available. Have gloves, masks, and gowns available because you never know when you might need them, and you don't want to have to go hunting for them. Always practice proper infection control techniques when you're administering medications because we want to prevent infection to the resident, but also to you and your family. Medication security and safety. Make sure those medications are not expired. That seems like a simple thing, but it's important. You need to regularly check. Medications need to be stored correctly. If you have controlled substances, the best practice is that they're double locked in a permanently affixed container, and then some states have very specific regulations, so follow those state and federal regulations. And your facility may have policies as well. Keep that cart locked and those keys secured. If you have the proper supplies available on your cart, it's going to help you avoid interrupting your medication pass and increasing the risk of making a medication administration error. There have been studies that show the more time someone gets interrupted, the more likely they are to make an error, and that just makes common sense. It's also going to help you avoid leaving the cart unattended to retrieve supplies because we don't want to do that, and it's going to make sure you're not increasing the time it takes to complete your med pass. If you constantly have to go find more hand sanitizer or gloves or tissues or cups or a medication, your med pass is going to get longer and longer, and you're going to be at that crossroads between safety and accuracy and time, and you don't want to be there. This is a huge list, but you can see there's little boxes so you could check things off. I put this together so that you might have an idea of what a medication pass setup checklist for supplies would be. I don't understand why every facility doesn't have one of these. You should have a checklist before you get your med pass going, and you should make sure you have all of the supplies on it. Now, this checklist has all the things I thought you might need, but you might need to take things off or put things on based on your resident population, and that's okay. I just think, we go to the grocery store, we have a list so we don't mess things up and we don't have to go back. Medication pass, to me, a little bit more important. We want to make sure we have a checklist on it. So get that ready, check it, be a good friend, employee, and coworker, and restock items on your cart. Don't just leave them for someone else to restock, and make sure you reorder those medications as needed. If you have food and beverages on the cart, only food and beverages used for the medication pass should be on the cart. Absolutely no personal food or drink. If you are fabulous at your job and families love you and they bring you food and drink, wonderful, good for you. It doesn't go on the cart. So you politely say to them, you know what, I'm not allowed to have this on the cart. I appreciate so much that you would think of me and bring them. Perhaps you could give them to so-and-so and they'll put them in the break room for me. Or I'll come back and meet with you later and I will put them in the break room because I'm not allowed to have them on the cart. And that also goes for you if you are tired in the morning and you want to bring a Coke and you need your coffee cup, or maybe you're thirsty, or maybe you feel like you need a snack and you're just going to have some of these on the cart. Absolutely not. That is what the break room is for, not on the cart. All food and beverages should be labeled with the date, including water, time opened, and none of them should be expired. And we've got to protect against contamination. So all food and beverages and straws need to be covered. Spoons need to be held in the cart with the part that goes in the mouth down. Same thing for mixers. We don't want them up because you don't want to grab them like this, okay? You don't want to be touching them and contaminating the surfaces, okay? If you have refrigerated items, make sure that you have access to them and that you're properly maintaining them. Don't allow them to stay on the cart in between medication passes. In any medication storage area, be it the medication room or in the cart, you want to separate your internals from your externals, okay? And if you don't understand which ones are the internals or externals, we have a really wonderful, on OmniView, recommended storage document for reference, and it tells you a little bit about externals and internals, so that'll be good for you. Now, you also want to separate medications from chemicals. People like to use their Lysol and stuff like that, and whether you should or should not use that in a facility is a whole other argument. But you need to keep it separated from any kind of medications because you don't want any cross-contamination. These things are toxic. You don't want to ingest them. If possible, I highly recommend separating medications by route of administration. So eye, ear, nose, throat, topicals, all separate parts in the med cart because that's going to help reduce your risk of medication errors. You're not going to grab the wrong thing. Responsibilities. When do medication responsibilities start? Well, you'd think they start as soon as you take over the cart, but they actually start a little bit before that. They start as you prepare to take charge of the cart. So as you take over the cart from the previous shift, if there are controlled substances or other items that the facility tells you you need to count, so maybe antibiotics or warfarin, they like to count those to make sure you haven't missed a dose, you have to count them. The person who's leaving and the person who's taking the cart over both should count. And I don't mean the person leaving counts and leaves, and the other person comes in and counts and says, okay, I verified that. You count together. You both read the count list to make sure the declining inventory is accurate as you compare it to the medication blister pack or whatever you have. You make sure that it's right. You check the actual inventory. And then both people sign the shift-to-shift count book if it's correct. If it's not correct, you've got a problem. Do not leave. If you have to go pick up your kids or your mother-in-law, you're going to need to make arrangements. Immediately investigate, contact your supervisor, follow the facility's procedure for an incorrect count, and resolve it. This is kind of a busy slide, and it tells all about survey implications. It tells you what a surveyor would look at if they identify misuse or diversion, which just means stealing, basically, of a controlled substance. So they say, hey, you know, they should consider and investigate these requirements. I'm recommending to you that you read this slide, especially if you're a director of nursing, an administrator, an assistant director of nursing, any kind of nurse management, and realize these are things you also need to be looking into regularly as well as when you suspect diversion. So quality of care would be a great example. If you think someone's stealing from a resident and they might be in pain, you need to check this. Make sure that if the pharmacy people came in and said, hey, you know what, you're going to have a problem with diversion, you need to do this, this, and this, that you did this, this, and this. Look at the clinical records. Are we signing off that we're taking out medications, we're taking out Vicodin, we're taking out Ambien, but then it's never listed on the MAR that anyone got it? And make sure your quality assurance and assessment committee, your QAA or QA committee, looks at this regularly, has a process. I wanted to put this in because I think people just get caught up in the, you know, oh, I'm scared, something could be missing thing, and they forget about the most important thing. F-tag 224. Whether or not you get F-tags doesn't make any difference. If someone's medications, controlled substance or not, are diverted, they're not being used appropriately, they're not being given to the resident, they're stolen. This is misappropriation of resident's property. It's stealing from the resident. Now, the state agency is recommended to contact local law enforcement, the Drug Enforcement Agency, so the DEA, the State Board of Nursing, the State Board of Pharmacy, and possibly the State Licensure Board for Nursing Home Administrators when they see stuff like this happens. Some of these are the same people that you, at your facility, if you identify drug diversion, need to report to yourself. You don't hide it under the rug. You don't keep it internal. You have to report these things. Now, if the count's correct, you don't have those problems. You sign the book. The person leaves, and now the cart, its contents, and the keys are totally your responsibility. You're saying when you sign that book, everything was fine when I took it over, and from here on out, my entire shift, anything that happens, it's all on me. So don't give your keys to anyone. Keep them with you. Don't hide them in the med book or anywhere else. It's not a good thing to do. The cart needs to be locked when it's out of your control. My definition of out of control is when you cannot see it, so if your back's to it for any reason, even if you have it in the doorway and you're giving medications, or you can't touch it. So if I'm very far away from it, and I'm not that tall, and I can't touch it, it's out of my control, it needs to be locked. Controlled substances. I have a little symbol for class 2 narcotics here. You may have different scheduled medications in your facility or in your state that have very specific regulations, and you should follow state regulations and federal regulations about keeping those secure. A best practice, as I mentioned, is keeping them in a separate, locked, permanently affixed area. If you have a lockbox for controlled substances inside the cart, it should remain locked when you are not removing controlled substances from it because it minimizes the number of times someone's going in and could take medications where it's not documented. And see, that's a lockbox, and the cart's locked as well. So what people think is, well, you know, I need to keep special items in there. So, you know, maybe you have a very special compact or something fancy that you want to keep safe, or someone has their batteries or their hearing aid that need to be kept safe. You know what? Find a different place for it. Only drugs in the med cart and only controlled substances in the controlled substance cart or lockbox. If you don't know what a chain of custody is, it's basically a timeline. Now, I highly recommend that you maintain a documented chain of custody for controlled substances. So it starts when you receive the controlled substance at the facility. Someone documents that you got it, who they were, how many you got. Then each dose of the controlled substance that's used or wasted, documented. Initials, date. We know exactly what happened. If the resident takes all of the medications in that blister pack and it's completely down to 0, the count sheet says it's completely down to 0 as well, and we keep a record of that. If they did not use it all and we have to destroy it, there's a record of destruction. So you need to know from start to end what happens at that facility with every single controlled substance. And surveyors will sometimes say, I've got 5 people. They all had controlled substances. I want you to give me all the records associated with this from the time they got to the facility to the time you destroyed them or they got used up. I've had this happen at facilities. Fortunately, my facilities were very good, so this wasn't a problem. But it could be a very big problem if you don't have this in place. Keep a chain of custody, keep things documented. This is a list of references that was used in this presentation. Again, my name is Carrie Allen and I work for Omnicare. We are here to help you as you need.